My name is Mary Krinkie, and I'm with the Minnesota Hospital Association, and I have with me today my colleague,
Joe Schindler with the Minnesota Hospital Association.
And Joe's our Vice President of Finance, and we are going to get into some of the numbers that we have estimated, both in terms of the loss of the premium tax credits as well as the impact of H.R. 1. I want to talk a little bit about both the inactions of Congress as well as the actions of Congress. And to Senator Nelson's point, I just want to comment, we are extremely hopeful that perhaps a deal can be reached and that these subsidies to help people purchase their insurance on the exchanges will come to fruition. But if that does not happen, the hospitals have estimated what the loss of this coverage will mean to both the hospitals as well as to our communities and to individuals. So as was also mentioned, hospitals are the only provider that's open 24/7, 365 days a year, and will see anyone in the hospital emergency rooms regardless of their insurance status or their ability to pay. Just as a reminder, last year, 40% of our hospitals had negative operating margins, so we are not in a very good financial position right now to absorb any additional losses. I want to start out with the tax credits, and the other speakers have mentioned the specific numbers, and boy, that presentation from Mincher was really revealing about how much of an increase this will be for individuals. It's really hard to predict the exact number of individuals who will choose or simply not be able to afford their insurance. We are going with numbers from DHS, and DHS estimates that it'll be about 60,000 Minnesotans who will lose their ability to purchase health insurance because they simply can't afford it. So for our analysis today, we're using the number 60,000. I recognize that that number could change based on if things change in Washington. This will impact rural Minnesota to a greater extent than the metro area, primarily for two reasons. Number one, farmers are usually purchasing their own insurance. And number two, the metro area has more large employers that provide insurance for their employees. And in rural Minnesota, you have more small businesses that frequently can't afford to do that. So this will impact greater Minnesota more so than the metro area. This no doubt will lead to increases in charity care for hospitals as well as a loss in payments that we receive from those individuals who do seek healthcare services. So, but before we get into the numbers, though, I do want to talk about what it means to a community and to a hospital when there's increases in charity care. And to be clear, the last thing that a hospital wants to do or their board of directors wants to do is to close a hospital. So that is the last resort. But in the interim, hospitals, when they're faced with financial challenges, will be forced to reduce services. And unfortunately, we're already seeing that in some communities. So what they do is they evaluate which services they're currently subsidizing at an operating margin loss, and those frequently are, and you've seen this before, mental health services, OB services, dialysis, subsidies to ambulances, and closing clinics. And that's been the recent occurrence that has happened with closing of clinics. So when that happens, it doesn't just impact the hospital, it's really devastating to the community. And I think that one message that's really been missing, those services close, it doesn't just impact the Medicaid population or the uninsured, it impacts the whole community. When those services go away, they go away not just for those on Medicaid, the whole community loses those services. And it's not just the people who are using those services now, it's the people who need to use those services in the future. So it also was talked about, what does this mean for the individuals? And quite frankly, it's really, really hard on these individuals. They're going to have to drive a longer distance, which in rural Minnesota, it could be another 100 miles. There's also fewer providers, so maybe you have to wait longer for your appointment. Maybe now you're waiting, instead of 3 months, you're waiting 6 months to get in to see a provider. So this adds, as it was mentioned, this adds to the cost of providing care because the individual has delayed services, and it also means they suffer from deteriorating health. Maybe they can't work their job anymore. So there's a lot of implications beyond just the walls of the hospital. So I wanted to mention that first before we dive into the numbers. So I do want to share some numbers. We've looked at both the impact of losing the tax credits, the premium subsidies, as well as H.R. 1. And these numbers are not in isolation. So the charity care, I'm sorry.
Madam Chair, could I
Senator
just ask a
Nelson.
brief question so I make sure I understand all the good information that you're going to be bringing? Is your information losing all the tax credits or just the COVID-related tax credits? I just want to be really clear on that.
Thank you, Senator Nelson. What we have done is we're using the number and recognize that that number, we really don't know exactly who's going to drop purchasing on the exchange. We're using the number of 60,000 because that's the number that DHS has said. Those are the number of individuals who will choose or be forced to, I want to be clear, not be able to afford their insurance on the exchange. So our analysis, and we'll get through these numbers, is based on a number of 60,000 for losing their coverage on MNsure. Then we're going to get into H.R. 1 next, okay? So that number could certainly change. So I want to recognize that. But our financial estimates are based on 60,000 people losing their insurance that they currently have on MNsure. So we've estimated, and Joe will go through the numbers here in a minute, how we got there. But we're estimating that charity care in hospitals will increase by $115 million. $115 million annually for the individuals who purchase their insurance on the exchange. We also are estimating a loss of payments to hospitals of $161 million. That is a conservative number because we took 30% of the overall healthcare spending. Hospitals may actually be more than 30% of the overall healthcare spend, but that's the number we're using. So that comes to $276 million annually for the loss to hospitals from people losing their coverage on the exchange. Now that number is not in isolation. We also have what's going on with H.R. 1. So DHS has estimated that under H.R. 1, 140,000 individuals currently on Medicaid would lose their Medicaid eligibility primarily because of work requirements or the 6-month redetermination, sort of all together the different aspects of what is in H.R. 1. 140,000 Minnesotans would lose their current coverage. So we've done some estimates on that, and that is pretty significant. It would be about $269 million a year in charity care increases and $354 million a year based on lost Medicaid payments. So combined, that would be about $623 million a year. Now, that does not start until 2027. So we are hopeful that there can be improvements in technology and this 6-month redetermination. We just met with the counties this morning. We are doing everything we can to see what we can do to handle the 6-month redetermination. It's going to be very difficult for DHS, the hospitals, and the counties, but we're working on that. But if nothing changes, and it's 140,000 people that lose their coverage, it's a hit to hospitals somewhere around $623 million. I want to be clear before I turn this over to Joe that the nonprofit hospitals and health systems in Minnesota are already in a pretty precarious position. So we know that we will be forced to close additional services if these cuts come to full fruition, and we're going to need your help. We can't maintain the level of services we have 24/7 unless something changes. So with that, Joe's going to walk us through the numbers, and I hope you all got a little handout sheet that was passed out. Thank you, Madam Chair.
So, Madam Chair, I realize we're running a little short on time, but I'll just take 2 or 3 minutes to go through this front and back one-pager.
Thank you.
That is dense with numbers. And if I start on actually page 2, which is the ACA, Individual Market Subsidies Impact, what we've done is Again, we're using 60,000 people that would disenroll from the Affordable Care Act programs, individual coverage. Excuse me. And the way, what happens to those patients? Where do they go? Quite frankly, most of them will end up in the hospital emergency room. So we're estimating about 40% will be seen in the emergency room with an average cost of about $2,500 per encounter, leading to about 60 million of that total, of the total number that we came up with. And then some portion of those patients will be admitted to the hospital for inpatient care at an estimate of $9,800 per stay, which adds up to $53 million statewide. And then some will be seen in clinic for a total of around $2.5 million statewide. So those are the numbers that comprise our $115 million in charity care costs that we expect to see if Congress doesn't act and if these premium tax subsidies aren't restored. In addition to the revenue.
Mr. Schindler, can I interrupt for just 1 second about that? Is that sort of spread evenly across the state? Do we know if there are areas that will be impacted more severely than other areas?
Madam Chair, that's a great question. We think much of this could be more hit on in rural Minnesota, partly because the individual market is focused on individuals, farmers, small businesses, whereas in the metro we have larger businesses, more group coverage. So for that reason, we think this hits harder in rural areas.
Thank you.
If we go to page 1, reversing order here and going to the impact of HR 1, we're talking about Medicaid cuts. And there again, we're using DHS's assumption of 140,000 people estimated losing coverage. And this is annual too. I mean, it doesn't start till next year, but this will be year after year after year. And as Mary said, we have concerns about the state and county's ability to keep up with all the new re-enrollment requirements. But that said, we expect that about 40% of those newly uninsured individuals will show up in the emergency room at about $2,500 per encounter for a total of $140 million worth of uncompensated emergency room costs, in addition to those that will be hospitalized in inpatient care at an average cost of right around $10,000, total statewide of $123 million. And then again, some people will be seen in clinic for follow-up or pre-hospital, and that totals $6 million. So that's where we get our $269 in additional estimated costs. 269
million.
Yes, what did I say?
$269.
Oh, sorry. In addition to, the revenue loss from Medicaid coverage of $354 million. Now, there is a cut that's happening as of today, and that is that the changes to emergency medical assistance, which was funded 90% by the federal government, has, as of October 1st, as I understand it, has been reduced down to 50%. And so that cut is coming immediately, and we assume, since it's hospitals that are generally using the emergency medical assistance program, that we will take most all of that cut, including as of today, that's $13 million annually. In addition to cost sharing, so putting co-pays on Medicaid individuals, which by the way was tried about, 10 or 15 years ago in Minnesota. It was a failure, and most hospitals had to swallow those costs. And so that's another $3 million on hospitals statewide. I'm really not getting into the Medicaid directed payment program that was intended to help hospitals restore some of these funding cuts that we already absorb in the Medicaid program, but those are being phased down over time. The program itself is being phased down, the assessment side as well as the reimbursement side being phased down to Medicare payment levels, which are below cost in and of themselves. The downstream effects of this, in addition to this, are under the continuing resolutions, Medicaid DSH program, the disproportionate share funding program, goes away. That means places like Hennepin Health, North Memorial, Children's Hospitals, and all those that do a disproportionate share of serving Medicaid residents, their funding will go down. effective immediately because of the DISH cuts. And then finally, as fewer people are in the Medicaid program, it will have a downstream effect on hospitals that qualify for 340B drug discount funding. Some of those hospitals will lose that ability to get lower cost medications for their patients. So with that, I'll pause for questions.
Thank you very much. I know we are hoping to later in the year do a deeper dive on rural healthcare and rural hospitals and EMS services in general. But just based on your understanding of where hospitals across Minnesota are right now, and based on these numbers, these seem terrifying to me. How many hospitals and clinics will we lose?
Well, I can say that 77% of the hospitals losing money are in rural Minnesota. I'll leave it at that.
Thank you. Senator Mann.
Thank you, Madam Chair. I just wanted to clarify one thing. We said that 60,000 Minnesotans will be priced out of healthcare, and another 140,000 will lose Medicaid. And we're going to cut the Medicaid days associated because of the federal bill. And on top of that, they cut emergency medical assistance by 50%. Is that correct?
That's correct.
Thank you.
Thank you very much for your testimony.